one of the other things worth talking about in biologics is not just who to start, but who to stop. One of the things we also don't know is what is an indicator that somebody's responding? Do we wait a year because of exacerbations
I was
or
going
outcome?
after that. In other words, you give the drug, you look for an indicator, boom, it goes down, or, as you implied,
when I started with omalizumab, we started the clinical studies probably almost 20 years ago. My partner and I decided we couldn't tell a patient this is forever therapy. We had to give them some endpoint, something to shoot for. So we said we're going to continue this biologic once a month for 5 years, and then we'll evaluate. We'll sit down with you and do something. Since there is such an overlap of biologics, I'm going to say something that's extraordinarily important. When there's gray areas in chronic disease, whether it be cancer, whether it be rheumatoid arthritis, we have to do something called shared decision-making with our patients. We have to use shared decision-making tools, decisional aids, to help us so that the patient can understand the perspectives there are to his treatment or her treatment and what the options are, and make that informed decision. They know what's best for them. We may know the science and can explain and answer their questions, but in gray areas where there's such overlap with these biologics, it comes down oftentimes to a patient decision made with the physician consulting.
Taken as a group, what is the experience you guys have, that clinicians as a group have with the biologics in the treatment plan, and what are the challenges when you use these biologics? You want to start in a very broad sense?
Challenges is getting pre-authorization approval.
Fortunately, that's sort of the process when you have a newly launched, very expensive therapy that's indicated for a specific patient population.
One of them has been on the market since '03.
He's been using it for 20 years.
Yeah.
Omalizumab.
Well, you know, I'm going to differ a little bit in that I understand. I worked in managed care for almost 40 years, so
well, there you go.
I understand the perspective. And it is difficult. Certainly, we want the right therapy for the right patient, right time. That's easy to say. But in my practice in the inner city, I often will see patients that come in. I just published a study that for a year and a half, I followed every patient that came in with severe uncontrolled asthma. And we looked at their records and we saw whether they had ever had any biologic discussed with them. And we found I had to go to 31 patients before I found one patient that had ever had it discussed. Really? So,
by whom?
By any physician. Was in any records, or the patient said, nobody's ever told me about that. The average number of hospitalization ER visits in this group was over 4.5, I think. So lots of hospitalization, lots of ER visits, and oftentimes I'll see patients that come in like that. In my private practice, before I was in the inner city, I'd see patients that came in maybe 1 or 2 ER visits or hospitalization. And it was kind of a hard call. It's not a hard call when somebody's in the hospital 4 or 5 times a year, is on maximum medication. All they do is keep switching them from one inhaled steroid LABA to another inhaled steroid LABA. But I think in both groups, you sit down with the patient, you go over why, and here's, I think it's really important to talk to the patient. You want to get good adherence. You use the I words. I think that I would like your asthma to be better, okay? I think we can have hope that it will get better, but I think it's not getting better. And instead of trying to give them some false sense that you know that if they take this drug, they're going to get better.
What would cause you to switch off some of these older treatments and move toward biologics in terms of patient population?
Usually it's exacerbations, and that's a huge problem because we don't have a good way to track exacerbations. Right now, we track them by asking the patient. That's as reliable as asking them about albuterol, okay? Not very reliable. So I think that we need a better way to track those bursts of oral steroids. They get on the phone or in the ER or get called in the middle of the night. Once we have that, that's the key, because the best indicator of future exacerbations, which managed care would love, is past exacerbations. So when we see that pattern of exacerbations, that usually, and a Th2 phenotype, that pushes us to start talking about biologics.
And this is where we can really work together, by the way,
Yes.
managed care and doctors. I mean, you have data that we need. Number one, you know how many controller therapies they're really using, how, at least filling, how many relievers they're filling. You also can see the exacerbation rate. If we can work together and identify those patients, it's going to be cost effective for you to think about biologics in them, but also if they're not adherent, we're going to have to figure out new mechanisms to gain their adherence.
But we need it at the point of service.
Yes.
We can't have it 3 weeks later in a report of 20 of our patients.
Yeah, the letter that says, is this helpful?
You have to work with us. We have to use digital technology in the future. They're going to be built into inhalers so we can tell if they're taking the inhaler properly and how many times they took it and where they took it. We need better ways to track those oral steroid bursts, and those things will happen in the digital world.
And also, we as physicians have to be partners with you, and that is sometimes part of being a physician is we want to make people better. And the mistake we're making is when we see somebody in poor control, if they don't have the phenotype that's going to respond to a biologic, we need to feel our pulse and say, this isn't going to work for you. And to put them on an expensive medicine that would make maybe forever, I think we have to really hold off on that.
You brought up a good word, switching from your traditional products to the biologic. You're not switching, right? This is on top of
Is that right?
standard
On
of
top
care.
of.
So you're not
Yes.
going to DC the
No,
Wabasabas.
That is the other rationale for, again, at least initially trying to manage these therapies. This is not intended to replace.
Although some
prior-
theorize if these would be cheaper, and as we move off to every 2 and maybe every 6 months in the future, this may be the standard of care in the
Maybe.
future.
In the
Yeah.
future, but not.
And it may
not
be
today.
that there's if you start some of these therapies young enough, there may be a preventative aspect. But I think you hit a real important point. Yours is a great point. When we looked at all the patients, we had over 300 that were on omalizumab, was the only biologic. We found they fell into 3 categories, which made sense after we saw it. 30% of them, oh wow, they didn't need any of their medication. They threw them all out. They stopped. They felt great. 30% of them still needed a fair amount of medication, but they decreased. No question. And 30% of them still needed fair amount of medication to maintain control. So it's not always, oh my God, it's because there's that bell-shaped curve.